a rundown of this webinar today, we are going to set some ground rules first. So the first ground rule is that if you are not speaking, please you off your mic so we don't get a lot of background sounds. And if you know you're in an environment that is a bit noisy, it's advisable for you to use the chat box rather than unmuting yourself to speak because it's going to create a lot of noise. So that's the first ground rule. And the second ground rule is that let's try as much as possible to make use of the chat. If you have any comments during a particular presentation, it'll be good you leave it at the level of the chat rather than interrupting the panel discussion. Because at the end of it, we are going to leave a session for question and answers. So if during the conversation you have any pertinent worry, I'll advise you jot it down. So during the time for question and Q&A, you unmute yourself and you go ahead with your question. I think that's the basic ground rule we have. So that said, we are going to have this rundown as an agenda. So we are going to begin with question and answer between the moderator and our panelists. And after that, we are going to have some question from Kendria addressing Dr. Ignatius. I think this is a special slot she requested to be inserted in the program today. So at the end of the Q&A session between the moderator and the panelists, Kendria will ride on with whatever she has prepared for Dr. Ignatius. Then immediately after that, we're going to ride on straight to the Q&A session where the participants can post their question. And you can address the question to a particular panelist, or you can leave it open for anyone to take it. Like I said, this is an avenue where we are trying to brainstorm on ideas to make sure that we give the patient the best care they need as doctors and as nurses. So if you have any pertinent question, maybe not related to what we discussed today, but still around doctor and nurses collaborating to make sure that the patient receives the best care they need, I think you can go ahead with your question, and you can, like I earlier said, you can address to a particular panelist, or you can leave it open for any of the panelists to take it. So that said, I think everything is clear and we know where we are and what we are supposed to do at this point in time. Please just let me confirm. Dr. Ignatius, are you with us? Okay, probably still not there. So in that case, I think the panelists available, Dr. Yempo, Dr. James, Mr. Maxwell, Stanley, and Kendria. Okay. So why don't to introduce a member of panelists so that we know whoever is talking to us and what position they have and their word of experience. So I'll begin with please a minute. Okay, I'll begin right on with Kendria. Yeah, she's a nurse and a healthcare writer, and she's also a speaker. She's from Cameroon, but she's now based in the UK. Nursing to her is a commitment, as she's always fascinated with putting smiles on people's face. So apart from being a nurse, she also loves reading and writing. Then the other member of panelists is Mr. Ndasi Maxwell. He is the African leader of nurses in charge. I think this is a title he recently held. He's a nursing diplomat and also a university lecturer. Another member of panelists we have is Dr. Fomukong James. He's the head of service of internal medicine in Cambe Regional Hospital Annex. I think those of us from Cameroon know where this is found. And he's in charge of the sickle cell clinic the non-communicable disease clinic, and the malnutrition unit at the regional hospital annex in Camden. The other member of panelists is Dr. Ignatius. He's a consultant neurosurgeon, and he holds key position as the Secretary General of Continental Association of African Neurosurgical Society. He's the Secretary General of the Cameroonian Society of Neurosurgeons and the Deputy Editor-in-Chief of the Journal of Global Neurosurgery. And additionally, he's a senior lecturer of neurosurgery at the University of Bamenda here in Cameroon. And the last member of our panel, who I'm going to introduce now, is Dr. Yempu. And I think we are here thanks to her efforts. And she is a member of the nurses in charge. She's the CEO of Nurses in Charge, and she's a family nurse specialist. So I think, please, there's somebody talking behind. Okay, thank you. So with that said, we know who our panelists are, and so we know their capabilities, and we know that they are well versed with this topic of discussion today. So we'll kickstart the panel discussion. I don't know, the person that prepared the slide, please, can you put on the slides?
Absolutely. Give me a second, please.
Okay, thank you.
Can I share? Let me see if I, yes.
Yeah, you can.
Please tell me when you need me, yeah? Thank you.
Okay. Thank you very much. So like we see on the first slide, it's a doctor-nurse relationship issue which we are discussing today, a critique on how to foster mutual collaboration and eliminating the existing Cold War. Next slide, please. Okay, so the objectives of this meeting, like I earlier said, is just for us to look for means to discuss, to brainstorm, and arrive at conclusions to help us mitigate any existing Cold War. Please, next slide. Okay, so thank you very much so far for your ears. I would like to call on Dr. James. You've been working in a rural setting for quite some number of years now. So I would like you to share with us any root causes that you think might be the reason why there is always this Cold War that exists between doctors and nurses. At times, even if they aren't voiced out, any person who comes through a health facility where there is this Cold War already knows that something is happening between the doctors and nurses. And I also like for you to maybe discuss on how this existing Cold War can impact on patients' care and the healthcare team. Dr. James.
Thank you, John Paul, and good evening to all the participants. I hope all of you can hear me.
Yes, I can get you.
Thank you. Yeah, as you rightly said, I've always been working in the rural areas, resource limited settings for quite some time now. And first and foremost, you use the word Cold War, but I think the doctor and the nurse's relationship is, I'm not sure it's war. I think it's more of love. I've seen several of your batchmates getting married to nurses. It's not really Cold War. But that notwithstanding, in fact, there are challenges in collaboration in the hospital. I think that's what you mean by Cold War. And what we can think or what we can say about possible root causes is that I think there is, first of all, a gap there's this gap of talking about our setting, of course, there's this gap of knowledge between the nurses and the doctors. And in collaborating, sometimes we forget that we expect, sometimes the doctor can expect the nurse to, I don't know what I would, if I would say, be at the same level of knowledge with him. Taking into consideration our setting, of course, we know, especially in a resource limited, in a remote area where we are, sometimes you don't have very highly trained or field nurses which can carry certain tasks. And so when we expect the nurses to do certain, to carry out certain activities which are maybe within their scope, but for certain reasons they haven't been trained in that, you end up being disappointed. And if you are disappointed, and you can frustrate them with their work. So the gap of knowledge already is an issue, which can be a reason. Personal ego or pride. I don't know what the pride that they give to the doctor, because as a doctor we are seen as demigods, and maybe the respect, or I don't know, I can call it the respect, but everything around the position of the doctor might create frustrations to the nurses. Like, I will take an example in terms of bonuses. When maybe in terms of bonuses, like when they're sharing bonuses in the hospital. If when the nurses are aware about like the gap between them and the doctor, that as well can contribute in fact, fostering this climate of Cold War in the doctor and the nurse. Yeah, I think the gap of knowledge and the pay package between the doctors and nurses, I think it's an issue, like what we have observed, or what we face mostly in this our area, which are challenging us sometimes in collaborating with our nurses. But I don't think there's a war. I think it's just about human-to-human interactions. And when those things happen, you just find ways to hold them down. But I think the gap of knowledge is essentially the one that we deal mostly in the units, like when you get carried away by it, or that was supposed to be done or has not been done the way you're expecting. Or the nurses, you remember when we were still back in school, we had this, what I would call anti-nurse. You know, why we learn in the classroom, you come in the delivery room, he will tell you that we have always been doing it like that, and it was working. You bring your evidence-based medicine here to confuse us and create that climate of tension. So I think that's what I can say so far.
Okay, thank you very much, Dr. James. I just learned Dr. Ignatius Esene is with us. Doctor, welcome on board. Hello, Dr. Ignatius. Okay. So I think he will join us subsequently.
Yeah.
Thank you very much, Dr. James, for that. Okay, Doc. Thank you for joining us.
Yeah, thank you.
Okay. Dr. James, thank you for that wonderful insight and emphasizing on the fact that there is a gap in knowledge and also in finances that might trigger some of this. Dr. Yempu, you've been in another world. Probably you started from Cameroon and then moved over to where you are now. I don't know what Dr. Drem said. Does it hold the same way you work, or is there a difference? And if there is a difference, what do you think makes this different? And is there another cause you think might be triggering the existing Cold War between doctors and nurses?
Thank you, Dr. Jean-Paul. Can you hear me?
Yes, I can.
Perfect. It's a pleasure to have such a question. So I'm originally from Liberia, West Africa, and I immigrated to the United States at the age of 16. So I have been in the US for, not giving you my age, but quite a few decades. Went to high school here, college, and now I'm a professional nurse here in the US. So with such a, I would say, divide in the professional realm of medical professionals, I cannot relate to what is happening in Cameroon, but I can relate to the aspect of gap in knowledge and the mention of evidence-based practice versus the old ways we've always done things. So my professional practice started as a nurse's aide. So I got certified to be the assistant to the registered nurses. And that history goes back to what I would also consider back then, which is the Cold War between nursing professionals. And that gap in knowledge is a major dilemma for the professional who has the gap in knowledge. It creates a level of we're getting a feedback, please. So when there's a gap in knowledge where the professional does not feel confident, it already creates an unease within that person. And if a higher order of professional comes and give them a task to perform, and that individual who does not have that knowledge base to perform such a task, that anxiety builds up. But let me remind all of us that being human, when you're anxious and someone does not approach you in the right manner verbally, it even flames the fire. So I can relate to that, growing up as a nurse's aide and transitioning into a registered nurse later on, and later on also progressing into a nurse practitioner degree. So it is that hierarchical of ranking that puts the individual who is of a lesser rank, meaning the nurses. When I say lesser rank in degree, but as professionals, we should all consider each other as at the same level to collaborate. And I believe that is why we're here today. So that is where I see, if there is no formal training in the task being performed, it brings a level of anxiety and less confidence in that task to be performed. And the communication gap as well create even more issues between the two professionals who are supposed to be working together, collaborating. I hope I answer your question. Dr. Jean-Paul?
Nyempo, I think he's lost connection. If we can wait just a little bit, you can continue, if you don't mind, with this aspect.
Absolutely, absolutely. We've been having internet connectivity issues, so I understand.
Hello.
Hello, Dr. Jean-Paul, is that you?
Hello. Yes, yes.
Did you hear what I had
Right.
to say?
Yes, yes, I did. I did. I'm sorry, my network was a bit stable.
Okay.
Okay. Thank you very much. I think if there's one key takeaway from what Dr. James and Dr. Yempo have said, is the knowledge in gap. Dr. Esene, welcome once again. Please, still based on this, on us trying to identify some of the root causes, we've heard of Dr. James emphasizing talking about the knowledge in gap, which Dr. Yempo has laid more emphasis on it and has given some explanation as to why that is existing, and also some financial gap. So you have worked in Cameroon, and I know you've done some surgeries out of Cameroon and in other areas. First of all, we would like to know if it's the same experience between nurses and doctors having maybe an existing core wall in the different areas in which you've worked. And if so, what do you think is the root cause? Is it still related to a knowledge in gap or financial differences, or there is something added to that?
Yeah, thank you so much for inviting me here, and thank you for giving the opportunity to speak. It's true that I apologize for joining late. It was due to internet connection. I totally go in line with what the previous speakers have said. It's true, I didn't get all of it, but I think there are so many causes that can account for this. In LMICs, in low and middle income countries, the issue is people often confuse the role of the nurse and the doctor, what they call a doctor, or let me say the physician or the surgeon. They forget to understand that these are two different professions. These are two core professions that that are unique in what they provide to the patient care. They're unique in what they provide in terms of the different activities that can result into the care of the patient. So it's not like, so we say the physician is superior to the nurse, or the nurse is superior to the doctor. They're all unique in the different aspects which they contribute to in providing care to the patient. So if people who are maybe conversant with this concept, if they are able to identify this uniqueness and understand that the rules of the nurse and the doctors are complementary, because the role of the nurse and the physician, I avoid to call the word doctor because you can have a doctor in nursing. So doctor does not just refer to maybe a doctor in medicine, or maybe a surgeon. So if you look at the role of the physician, surgeon, or the general practitioner, and that of the nurse, if you look at it from the perspective of being complementary, the complementarity, then things are actually going to work. But if you start looking at it from the point of who is superior or inferior to the other, then the problem actually comes in. Because as I always say, medicine is teamwork. Surgery is an example. Starting from the cleaner, the nurse assistant, the circulating nurse, and every other person that's involved in the patient care. If the cleaner doesn't take very good care of the operating room, you can have an infection. So no matter how competent you are as a surgeon, no matter how competent the competent nurses you have with you to work, at the end of the day, results are not going to be good. If you don't have a good, competent nurses there, for example, in the ICU after surgery, who are going to administer the medications to the patient, then every other thing that you did in the theater is not going to be of any use to the patient. So we just have to, I was underscore the word complementarity, that they are complementary, their rules are complementary, and each of them are unique. Okay, there's nobody being superior to the other, because what they offer to the patient care, there are rules that are totally different. So I think that's what I have to say at the moment, and so maybe when I'm given the chance to maybe give my presentation.
Okay, thank you very much, Dr. Isene, for bringing in that. And I think all of us here are learning, and we are learning a lot. Please, can you help us with the next slide? Okay. So we've identified some of the hitches, some of the root causes, and now we are trying to look for solutions. And like Dr. Esene said, there are two different professions and they are there to complement each other. So for this complementarity to come in place, there must be some mutual respect between these two professions. And so I'd like Kendria to come in and at least give us an idea on how we can cultivate a culture of mutual respect so that these two individual profession can coexist and know that, well, they are there to complement the work of each other and nobody is superior to the other. Kendria.
All right, thank you so much for that question. So I will first of all want to start mentioning that the scope of nursing practice is different from that of a physician. So it's going to start by, first of all, understanding that this scope of practice is separate. So I know that as a nurse, this is what I'm required to do. And the doctor, the physician is supposed to do this one. So if I'm a nurse and I'm able to understand that this is my role in the team, and I'm able to put up to my role, definitely it is already limiting any other weight or burden on the physician. But in a case where maybe I, as a nurse, I don't even know what my scope of practice is, and I'm not able to deliver what I'm supposed to do, it's already giving room for a lot of trouble already. So number one, I have to understand my scope of practice and know that this is what I'm required to do as a nurse. And secondly, we have to know that we are members of the same team, and we are working towards a common goal, and this goal is to make sure we are giving the patient the highest person-centered care that it can ever have. So I need to know that the doctor and I, as Dr. Ignatius earlier said, we are there to complement each other. So I come in, if for example, I see something that maybe the doctor has said something that I should do, because majority of the time the doctor, the nurse spends more time with the patient than the doctor will do. So I know not too much about the patient, but because I'm there to continuously monitor the patient, there are some changes in the patient that I will be the one to easily report to the doctor. So maybe if I report that to the doctor, and in the course of him devising a new treatment plan or so, and I see that there is something wrong with this, or I think maybe there could be maybe an amendment to that, I just need to approach the doctor in a very respectful way, knowing that we always have to keep that environment where there is mutual respect. The way there is mutual respect between each other. So I am approaching the doctor not like I want to challenge him or I want to make him know that maybe because I've stayed in the ward for maybe 5 years or so, I know more about patient care, but I'm letting him know that, okay, doc, think about this. What if we did it this way? It would have been better for the patient based on what I've observed. And if we are doing this, we need to also consider as much as we can evidence-based practice. So you as a nurse, you're just coming to tell the doctor what you think should be done based on your own thoughts, but it should be evidence-based. So you're coming, maybe if you can be coming in with the vital signs to say, okay, because of this vital signs, I think we can do this instead of doing that. So it is very, very important. And also the way we relate to each other. Like, for example, if I'm the nurse in charge of a ward, I should equally know that though the doctor is not there all the time, there is a lot that I equally need to ask him, like, okay, doc, I think, what can I do about this? We should always be able to relate in that manner. So from there, you can see that if I recognize, number one, that this is my scope of practice, number two, I know that I need to work in a team with the doctor and other healthcare practitioners, and then definitely there is going to be that that atmosphere where everyone is doing their job and we are just trying to come in and stand for each other. And also, one of the things that we can do to build this trust and respect is because, there is this confidence you develop when you become competent. So you as the nurse, you have to keep on trying as much as you can to reduce the gap in knowledge. Try as much as you can to continuously build your competence. Because when that comes in, the confidence that you have becomes like it increases. And from there now, our patient is not going to suffer from anything that we are doing. And if everything is working out for the greater good of the patient, then I think we are working as a team, and that is the common goal that all nurses and doctors should be working towards.
Wow. Wow. Thank you very, very much, Kendria, for that. And if there's one thing I took away from your message is that competence breeds confidence, meaning whether you're a physician or a nurse, try as much as possible to be competent. And so I would like Maxwell to come in and maybe give us a word on this aspect of establishing a culture of mutual respect. And Maxwell, congratulations on your recent appointment as the chairman for Africa Nurse in Charge. I think that's a big one. Congratulations on that. So added to what Kendria has said, I don't know if you have any other idea on how to cultivate this culture of mutual respect between these two unique professions?
Thank you very much, John Paul. Hello.
Hello.
Can somebody get me? Hello?
Yes, I can.
Yeah, we're getting you.
Okay. So I think everybody has been doing amazingly great. Thank you for the congratulations. And I think all the presenters, they have touched almost everything. I think it's just like they were reading my mind. Just like they were reading my mind. But I think there's one thing that I would just like to add. I don't know if you guys are getting me. Hello?
5 on 5.
Okay, so our current quest now, if you look at what's actually bringing the conflict between nurses and doctors, is more of the quest to lead. Today, nurses are trying to get out of the comfort zone of just being maybe look upon like a physician assistant or just being looked upon like a bedsider. No, nurses today, they have this quest of also looking at positions like being the director of health institutions, being general supervisors. I mean, they want to seek more positions in boardrooms and to certain levels, healthcare systems and healthcare policies, they are not actually there to grant access to nurses to assume this role. So until we're trying to create a forum where neither doctor nor nurse represent administrative positions like their respective positions, they're not doing anything. Like for instance, if the course of healthcare administration was being offered to both nurses and doctor, and at the end of the day, they could either select a nurse or a doctor to answer to the position of a director, I think it's going to go. But if you look at many times today, I think like I myself have schooled with so many doctors while doing my master's. At the end of the day, you see that when you even have internal nomination that are supposed to come, they'll still prioritize more of the medical doctor as compared to you as a nurse. So the government to certain levels too is acting strategically to make sure that this conflict stays. And I think that's one of the roles why they are supposed to revise some of their nomination principles and look into better criteria to see how to nominate persons at different posts of responsibilities, because today leadership too is a couple content, and majority of times the success of nurses comes always to the table of a doctor, and very few of them can actually realize that that are coming in from the nursing domain and being the patient at the same time. Doctors don't have this mindset of 1 or 2 times and I dedicate this success to you. It speaks a lot. It speaks a lot. And then the fact that there's also maturity. We lack this aspect of leadership maturity. And sometimes we like to put
I think Maxwell is having some difficulties with his network. Maybe you. Hello, Maxwell?
Yes, I'm there. Can you get me?
Probably he's going to join us in a bit.
I can hear him.
Can somebody get me?
Yeah, I can hear you.
Hello? Okay. So to certain levels, we must create a constructive environment where nurses too can assume leadership positions. Why not put a doctor too as a director, a nurse as a director of a hospital? It speaks well. And the moment we start giving them nurses this responsibility to actually show at what level they can prove out that their leadership, it will not bring out this confidence that they are lacking today. Because today, very few nurses are being proactive. And if you are not being proactive and being assertive a lot, so many people might not be freedom. So, and we keep failing in that domain, and all our success that we do on our bedside on daily basis keep answering to the praises of medical doctors. I think to certain levels, internal policies are supposed to look into ways through which we nurses too can assume some positions that I think is going to suit some status that people would respect. I think that's just what I would like to end from. I would like to end here now. Hello.
Thank you very much, Maxwell. I think that sang widen, and thank you for making that clear to some of us to know that, well, some leadership positions can also be held by nurses, and not necessarily only to doctors. It should be based on competence. Thank you very much for that. Please, the next slide. Okay. Thank you very much. So we are trying to look for solutions. We've heard Kendria give us a take on that. We've heard Maxwell give us a take on that as well. Dr. James, please, I want you to come in again and maybe give us an idea on some of the things you think can be done from a doctor's perspective on how to maybe promote collaboration between the two professions, doctors and nurses. And also if you think there are organization policies and support systems that need to be revised to make sure that this collaboration it's better than how it is. I think Maxwell already brought up an issue regarding that maybe the government should revise their nomination policies for certain positions. So Dr. James, I don't know, please can you come in and maybe give us an idea or a take on this aspect as well?
Okay, thank you again. Well, in this collaborative aspect, well, first of all, if I have to say something following to what Mr. Maxwell just said is, well, I don't know if we means having nurses at top position in big hospitals, but the experience is that since we are talking about Cameroon, we have nurses at the level of health centers, which are chief of centers. We have at the hospital level, they are general supervisors, which is an administrative post, and as well we have some district medical officers, DMOs, who are equally nurses. So yes, if we look at the proportion, it's still very low, but we are talking about collaboration in a hospital environment. So if you are looking at means to promote, in fact, to foster or to ease to fruitful collaboration between doctors and nurses for the well-being of the patient. I think this is at the hospital level. It's a day-to-day interactions, the way you treat your colleague, the way your colleague respond to you, and so on. First and foremost, I said the gap of knowledge was an issue because you can expect something or not. And I talk about financial consideration. I think even the leadership role has to do with financial considerations. You have to treat your colleagues with we mentioned respect, we mentioned we can say empathy, but I think on a day-to-day activity, you have to make the nurses you are collaborating, as a doctor, you have to make the nurses you are collaborating with feeling at ease. Because when somebody is in an environment where he or she feels love and he feels acceptance, he can produce more. For example, I would say you can make any mistake. You can make any mistake seems easier to correct. I will take an example. A couple of weeks ago, there was a sample that was taken from the patient, and somebody was assigned to handle it. It was a nurse, and in the course of our daily activities, she misplaced the sample, and in fact, it was so bad because we struggled to have it, and we had to try to. We looked everywhere, we could not find the sample, but we did not go. In fact, you don't go as a doctor in that situation. If you go ahead and maybe you can blame, you can only sanction and whatsoever. But at that position, you can make that mistake. You should make that mistake seem very easy to correct. I think making that step or that move for your colleague, it will build a climate of trust. Not that it will encourage the mistake, because in other hand, somebody can think that he can encourage her to keep doing things the wrong way, but no. I think many a times what I implement here is that when we have this little moment of tensions, I will always try to make that mistake seems easy to correct. And doing so, I'm actually inviting the other person to step in and collaborate with me so that we can correct that mistake. And many a times we have always had good outcomes. Than to enter is a climate of tension and fighting and disrespect, and sometimes even this form of scandals that we are seeing, unfortunately, in our society nowadays. Doctors, nurses, here and then, it's not an image to promote. So in that line, if I are to say collaborative, like Dr. Isene said, we are meant to complement each other. And Kendria also said the nurse step in to contribute ideas in the care of a patient. All those little ideas brought together help to improve the quality of services that a health facility can propose. So I think at any point in time, we should treat the colleague, be it the doctor, be it the nurse, with the utmost respect. There are several times that I have made some mistakes in prescriptions, but maybe it's something that the nurse is very sweet. You can easily call my attention, and so I don't think it's something that we need any governmental or NGO or whosoever to step in to arrange or to do something for the betterness of the relationship between the doctor and the nurse. But I think it's somebody that you are meeting every day, somebody you are bound to work with on a daily basis, and it's like a marriage. Like I told you at the beginning, I don't see a Cold War. I see more of a union. A union. Yes, at times the work of the nurse, the doctor will might take credit for the work of the nurse. But at that moment, it's the responsibility of the doctor to acknowledge the contribution of the nurse. You see, people like praise, all of us like praise, like appreciations. So if a team did something, you should not stand out as a doctor to take all the credit for yourself. Indirectly frustrating your colleagues that you have been working and struggling with. So that's what I can say on this point. We should try to interact. There are ways, I think it's more of mannerism than anything that we need a governmental decision or something. No. It's more of the way you're interacting with your colleague, your fellow brother or sister on a day-to-day basis. You should not do something that you won't accept that somebody will do it to you.
Thank you very much, Dr. James, for that insightful talk. And if there's one thing I took away from your message is that we should treat each and every person with utmost respect, with empathy. And I think that's what we need to be able to foster this collaboration in our day-to-day interaction as nurses and doctors. So that said, I would like to hear again from Dr. Yempo. I don't know, maybe do you have anything to add to what Dr. James have said and what Maxwell has put in?
Absolutely. I'm so glad that you called for me, because something that does not settle well with me is what the previous speaker, Dr. Timokon, am I saying your name right? I hope. You mentioned that your nation, I believe that is in the context that you do not need a non-governmental organization to tell you what to do. Is something that's happening in your home. But I also relate the story to a home, a marriage, as you mentioned. If your marriage is not working on the inside, over time, and the outcry of your wife goes out to the neighbors, you become a public display. And I believe this is the situation. If the situation in Cameroon between the nurses collaborating with the doctors or vice versa, if it was being handled internally, it would not be part of this platform. It would not be, this discussion would not be on that topic. But the fact is that the outcry of the nurses in Cameroon are beyond just collaborative efforts in practicing with their doctor of their co-partners in healthcare that it should be. It's actually extend to other issues in compensation. So when we come in to form a connection to acknowledge the work of nurses globally, we are finding these issues globally. It is not isolated to Cameroon. So we come in not as peacemakers even. We don't come to solve the problem, we come to empower those nurses. Apparently there is a lack of empowerment in these nations that we're encountering. There's a lack of empowerment in the United States for nurses. We're not being recognized for our worth, for what we bring to the table. So if you have just few nursing leaders who are in positions in hospitals, but the decision-making parties, there are few nurses. And in fact, research is showing that out of 90% of healthcare workers, nurses make 90% of the healthcare workers globally, but there are only 30% of those nurses on the decision-making table. So where the strategic decisions are being made, there are very few nurses' voices being heard there. There's a global issue. There's a global crisis. The outside nurses have reached the global platform. That's the reason. That's the premise. That's the. So we come in peace. We come to collaborate. The that goes behind. We offer those education, those trainings, the evidence-based practice that should be disseminated across the board so that nurses in Liberia, nurses in Cameroon, in China can have the same skill sets to provide quality care. That is what we're trying to leverage here. We're not coming to solve problems. We're coming to give nurses the tools they need to stand up tall, to no longer be walked upon, to not feel demeaned by their co-partners that should be the doctors, the radiologists, and you name it in healthcare. So I get very passionate about nursing struggles that have been years long, decades long, swept under the carpet in many nations. And COVID, actually being a pandemic, truly came as a flood that when it left, and it's not completely gone, but the aftermath is that a lot of things have been exposed. Just like any natural disaster, when it leaves, the debris is what we're seeing currently, and it's impacting nurses globally. So don't take it personally. This is not only a Cameroon problem. This is a global catastrophic event that's happening. And we are forming cohesiveness to say, for lack of better words, we will no longer take the backstage. We have been in the front page. We have been there when patients, when humans are born, we're there when they die, and we know them better than probably our doctors because they're in there 15 minutes and they're out. And the nurses are there 24/7. The nurses are even holding hands with those patients when the doctors are doing their rounds and leaving quickly because they have to go see other patients, but nurses are there. So we're no longer taking the back seat. And these organizations are coming to say, hey, I got your back. If you have questions, the doctor asks you to do something, they have not trained you, give me a text message on WhatsApp or just call me quickly. I will give you the backup information you need. Evidence-based practice, maybe at my fingertips, you may not have it there because of network connectivity, but on WhatsApp, we can connect quickly. So in all due respect, doctor, I will reiterate, we're not coming to solve your problems that have been pre-existing. We're actually coming to prevent further and future catastrophic events that will continue to happen, and nurses are being very much more impacted negatively. So nurses in charge, we're just here to give that extra boost that that nurse needs, who is working in the rural areas of Cameroon without support. It should no longer be that way. Thank you.
Wow, thank you very much, Dr. Yempo, for that clarification. At least with what you said, we have an avant-goal of what nurses in charge is all about, because a few of us are here and we basically had no idea what nurses in charge, what they are fighting for. So I think we now have an idea on what you guys are out for, and I think it's a credible fight and we'll get there one day. Thank you very much. And if there's one thing I took away from your message is that more nurses should be on the decision-making table in healthcare as well. Okay, thank you very much. Next slide, please. Dr. Tongowo, please, we'll get your question later. I can see your hand up. Let's rapidly wrap off with them, the panel discussion and then get your questions. Thank you. So we probably almost coming to the end of this panel discussion to start taking in your question. So now please, the slide before this. Thank you. Yeah, I wanted a few of the panelists to maybe share some case studies on and best practices. That's just share with us your example on maybe how it's been done in your hospital to ensure that there is this collaboration between nurses and doctors on a daily basis. And now I would like to hear from Dr. Esene. You are a surgeon and basically you work with nurses in the theater, out of the theater, and basically almost everywhere you go. I don't know, can you share with us some of the strategies you've used in throughout your profession to make sure that there is this collaboration between these two unique professions that are supposed to complement each other?
Yeah, thank you once more for bringing me in. I just want to really say I totally align with the comments made by Dr. Yempo, and then also some of the points that were raised by Kendria and Max. And not taking you back, but I just want to maybe underscore one thing. You know, the problem is deeply rooted in the fact that, especially in the developing countries, that doctors for physicians many years back used to maybe undergo several years of training. Okay, for example, 7 years in the medical school to become a physician, whereas nurses, maybe nursing assistant 1 year, then maybe state registered nurses 3 years to 5 years, and so on and so forth. So that's why at for a very long time, there has been this discrepancy, okay, in the rules of the nurses and the doctors. But I think things have actually changed because I think somebody was mentioning that you can have a nurse with a PhD in nursing, professor in nursing. So is a professor in nursing less than a professor in medicine? I don't think so. So it's all about the attitude of the physicians and the surgeons and then the nurses that are working in the setting. And also sometimes the problems are actually arise because you might have some traditionalists, I mean, some nurses who for a very long time have just been on the field without trying to maybe do some continuing education. So with the low professional training and low level of expertise, it's sometimes difficult for the doctor to actually engage in an academic discussion that is going to maybe patient oriented. So that's why, I mean, I think Dr. Yebwish was talking about the notion of evidence-based practice. So I think any physician or surgeon who meets a nurse who is well trained with enough expertise and experience, the respect comes in automatically. You know, sometimes you don't need to ask for the respect, but your contribution, what you're bringing on the table, if it is significant, I think you automatically gain the respect from the physician or the surgeon. So to give an example, I think a few years back, we wrote a paper about task sharing and task shifting in surgery. So again, people who are well traveled, people who have been to other systems will understand that, again, the nurse and the doctor, they are not in competition. They have unique roles to play in the inpatient care. So, for example, when I returned to Cameroon and I started practicing in the northern part of Cameroon, well, the anesthetist is a nurse, okay? She had been on the field for so many years. And my first assistant till now is not the medical doctor, okay? He's a nurse, a theater nurse who had been on the field for more than 30 years. So he has the expertise and he has the experience. So automatically he gains my respect. So I know that he has the competence. So when we are working, I respect his competence, his experience, and what he's contributing to patient care. Similarly, it's true I'm a surgeon, but I cannot play the role of the anesthetic nurse who is going to put my patient to sleep for me to do the surgery. So with all this in place, I think once you have a team and you define the specific rules which each person has to play in the patient care, it becomes very easy for you to work together. It becomes very easy for you to collaborate. Again, the most important thing is communication. And then the team leader has to actually define clearly the rules of each and everyone in the management of the patient. The person who sees the patient maybe the day before surgery, the person who is going to maybe take care of the wound dressing in the ward, all of them have a role which is very important. And as I said, none of these rules is superior to the other. Surgery might take place, maybe it might take just an hour or two to do the surgery, but the patient is going to be in the ward for 5 to 10 days. So the people taking care of the patient in the ward are not less than the person who actually did the surgery. So I think collaboration is very important, but for this to happen, there needs to be a good communication in the team with clear and well-defined rules of who has to play what in the care of the patient. Once that is done, I think there's going to be no competition. The team members are going to see themselves as being complementary rather than being competitors. And once that happens, it becomes very easy for them to. I have hardly had problems with my theater nurses, for example. At one point when I came, I said, no, when any patient that comes to the hospital with maybe a wound on the head, you should make sure that I actually come and do it myself, because I'm trying to mitigate maybe the complication. But I realized that I wasn't able to do that all the time, because I had to cover up a very huge population of about 10 million. It becomes very difficult. So I actually empowered the nurses who are most of the times in the hospital during taking the course to be able to suture maybe superficial wounds that are not, maybe the bone is not breached. So once we know who has to do what in the patient care, the conflicts are actually mitigated, they are reduced. It's never going to go, as I said before, because this what we call the Cold War is it is built within the system, where because of the traditional rule of or maybe of the traditional notion that doctors maybe have more expertise, they went to school for longer years than the nurses, so they always try to have that during the decision making process. But today, as I said, they are already extended nursing programs that go from the BSc through masters to PhD. So in terms of expertise, in terms of education, all of them can attain the highest level. The most important thing now is just for the policymakers to define the rules of each and every person that is going to contribute to or provide optimal care to the patient. Thank you. I'm done. Yeah.
Okay, thank you very much, Dr. Esene. I think that was a very, very interesting one, and it came to water down a lot of what has already been said and to shed more light on how we are supposed to go about this collaboration, which we've been talking for quite some time. So I would like Kendria, please, can you also share maybe what you guys do in your institution to make sure that there is this collaboration between the doctor and nurses? Maybe you have a different experience where you work. We're just trying to get case studies from different areas. So Kendria, please.
Yeah, thank you so much. So with regards to this, please, I would like to first of all mention that in order for this to actually work like the way we've been discussing, there's supposed to be this mindset shift when it comes to with nurses, like, you know, like Dr. Ignatius earlier said, when you have that competence, right, I automatically respect you. It's not like I'm not respecting you for you, I'm respecting you based on the content that you're bringing. So if everyone is doing the job and you have this mindset that's not just based on your now and based like a global mindset, and knowing that, because you know there is this stereotype that has existed in the nursing profession from the past, that nursing was something that was mostly done by those of very low families and maybe women. So that stereotype has been there for a very long time. So in order for us to step in and break this stereotype, considering the role nurses play in the healthcare system, it's very important that we try as much as we can to break that stereotype. And we can only break the stereotype if we are able to be competent and actually come to the front line and say, okay, the things you usually think about us, that is not what we longer do. We are able to do what we are trained to do. So if we start doing that, not just by saying that, okay, do this, we are doing this, we are doing that, but actually showing that actually I can assist the physician with whatever thing I'm supposed to do. I'm able to do my own work. I'm able to, you understand what I mean? That is going to help a lot. So first of all, we have to have this reprogramming of the mindset to not just see nursing as, you know, a bedside profession, but seeing it above a bedside, like Max earlier said, we should also be able to take those leadership positions. But the thing is, you cannot put someone in a leadership position if they are unable to deliver what that position requires. So it's all about, building competence over time and taking into consideration the evidence-based practice, and that should be reinforced at every point in time. So with most of the institutions that have actually been able to work there, you mostly see that, okay, the roles are well defined and everyone is trained at, even when you get employed, you're also trained on particular aspects. So you're not like doing everything, but there are particular things that you need to get trained. They still need to train you for, and from there now you can do your competence and you begin to practice. So you can see that when that training is still done again, is trying to reduce the chances of any mistakes and all of that. So it is very important that we adopt this kind of system, even back home in Cameroon, because most of the time you can see that when you just complete your training, you are employed somewhere. And if you're not able to push yourself to do that extra work to develop your competence, at one point you see that you are lacking, and at any point that you are lacking, the patient is suffering. So it's all about, just trying to be very innovative, to be proactive, and also to know that you are not just focusing on your now, but you're also trying to see how you can be diverse and try to absorb new things and throw away the old practices that we have always had in the past.
Thank you very much, Kendria, for that insightful conversation there. Competence at the end of the day. So thank you, my panelists, for your thoughts, and I cannot thank you enough. I suppose those of us who attended this webinar have gotten one or two takeaway from whatever we've discussed today. So we'll be riding on to the next session of this wonderful webinar, and that is Kendria. She has a slot with Dr. Ignatius. Kendria, please, you can take over from now. After which I'll suddenly come in. All
right. Thank you so much for the opportunity. Sorry, Dr. Ignatius. Sorry, I just have some questions to ask you, but because of time, I'll just try to summarize it as much as I can. So the first question I want to ask you is, how do you manage to influence the world of neurosurgery from Cameroon? How do you get to do that? And secondly, if just one advice that you can give young professionals in the health industry, if you want to give them just one advice, what would that be?
Thank you so much, Dr. Kendria. Well, talking about influence is, we just have to, I always tell my colleagues, my friends, that we have to see ourselves as unique. You are not better than anybody, and nobody is worse than you. You just have to see yourself as somebody who has been maybe sent on Earth for a mission. And of course, I mean, I was in the North America. I was there for some time before coming back to Cameroon. I mean, I've been to the North Africa, I've been to Europe, I've been to most of the continents. So you don't try to practice medicine in Cameroon like the way it is done in the US. I mean, it's a totally different setting. I think somebody mentioned about evidence-based medicine. It's a very important concept which is universal, but the way it should be implemented varies from place to place. Okay, for example, if I'm trained to use maybe an endoscope, okay, to do surgery, maybe for a kind of surgery that maybe is possible to do it with an endoscope or with a microscope. And on returning to Cameroon, only the microscope is available. Using the microscope to give my patient the best care is not inferior, maybe treatment or inferior therapy. We just need to understand that we try to provide care to our patient, take into consideration what they call the local plateau technique, the local what's available to you. At the end of the day, put the patient at the core of your work. If you have a passion for what you're doing, believe me, the results you produce are going to be very, very, very audible. How did we manage to maybe make the world know the work we're doing over the past few years? When I returned to Cameroon in 2018 with the vast traveling experience, I noticed that there are a lot of things we're doing here that are not known to the world. The first point is that we don't even document, write, and publish what we do. And I remember one of my mentors, he told me before, if you want to survive in your career, then you have to know one thing. You need to be able to write, publish, you post, or you're going to perish. I repeat again, you have to do your work, you document it, okay? You published, you post, or you're going to perish. So you don't come back, go and sit in my little corner. For example, I'm here in the northern part of Cameroon. Nobody knows where Garawa is. Nobody cares what you're doing. Nobody knows the difficulties you're going through. Nobody knows that I do brain surgery with nurses. I mean, that and the anesthetist, most of the time, it's a nurse, not a medical doctor. Nobody knows that sometimes you're operating and light goes off. That is your problem. People are facing their own challenges in the different parts of the world. Okay. So once you start working, make sure that you find time to document. Make sure that you try to practice medicine using international norms and standards. And as I think Dr. Kendria was saying, evidence-based medicine, that is a standard of, that's a standard that's used by almost by every person across the world. So if you are practicing medicine according to the standards, which are defined by the majority of the people, then you are going to be able to produce results that are recognized by the rest of your colleagues or their peers across the world. You need to be able to, you need to define a problem which you are solving. For example, when I came back home, I realized that research is a major issue, not only in Cameroon, not only in Africa, but in most LMICs, that is low and middle income countries. So we decided to create educative programs, okay, for research in neurosurgery. Okay, then people began to understand to understand that research is not something which is difficult. It's something which is easy. That we're trying to demystify what people used to mystify, what people used to make it look at something which is not terrestrial. So by so doing, we're able to write and publish what we actually do back here in the continent. So the world became interested in what we're doing. You know, North America, they're very interested in having data. Data is the most valuable asset. So Europe, North America, and the rest of the world, they become interested in data from Africa. So then we're able now to tell the African story using our own words, not people traveling from North America and Europe to come to Africa, do the work, collect the data, write and the story of Africa in their own words. So by so doing, that's what actually made us known across the world. We're not doing anything extraordinary. And as I told you before, it's a whole team, because we understood that with our travel experience, you can't do it alone. You need to have a team. Don't try to take credit for work done by the team. As somebody mentioned, credit, I think one of the Dr. Young said that, don't take credit from the work done by the team for yourself. I mean, that's being selfish. So make sure that every member of your team feels acknowledged for what he or she for what they are doing, and by so doing, people get to get interested in what you're doing. Don't try to just create or build followers. Try to build other leaders. Try to help others develop their talents. Okay, so by so doing, see, you actually realize that you're actually ramifying everything you're doing, and by the fact that you are developing more leaders, people become interested in what you're doing. So, okay, and you make them independent. Don't make people to be dependent on you. Again, so there's a lot to what we've been doing over the past 4 to 5 years. And as I told you, our simple maybe secret is just that it's just teamwork. We try to work as a team. We try to share the credit of the successes we deliver with the rest of the team members, and not try to be the superhero, because as I said before, nobody is more important than the other. We all have unique roles. So once people understand that they are unique, they're important in the results that are delivered by the team, they become more cooperative, they become more collaborative. They don't see you as a competitor. Yeah.
Thank you so much, Doc. Thank you so much.
Okay, Kendria, I guess you had that sorted out. Thank you very much.
Yeah, thank you so much.
Okay, please, I would like to hear from Stanley. He's a member of panelists and he has something to share with us. Stanley, please, you can unmute yourself and have the floor. And we put all of this because of him. It's his effort that we are seated here because of Stanley. Stanley, are you with us? Okay, probably not around. Dr. Ignatius, I suppose you had a presentation for us. Please, you can ride on with your presentation, Dr. Ignatius.
Doctor, did you just call for me? Sorry. Did anyone call for me? I just got here. I had to go. see my patient. Okay.
No, not yet, Dr. Tongowo. I've not forgotten about you.
Yeah, talking about the presentation, I think we've already discussed most of the points. I mean, that during this discussion,
Okay.
so I don't think it would be necessary because it's just going to be repetition. Yeah.
Okay, then thank you very much, Dr. Ignatius. Thank you.
Yeah. Yeah.
Okay,
Thank
so
you.
right on to the Q&A session. I think when Stanley comes in, we'll give him a slot. So, Dr. Tongowo, you can unmute yourself and ask your question. You indicated
Okay. Thank you guys so much. It was a good presentation, and this is something that's very close to my heart. Dr. Nyempo, I would really like to, by the way, I'm a doctor preparedness practitioner like you. I'm family medicine and psychiatry. This is very close to my heart. I own a practice here in Maryland. So I was in and out in between patient and bed. I kind of listened to the first speaker. They were talking about the reason between the friction between the nurses and the doctors. So this is just a comment, okay? I just want to comment that everybody in the healthcare, every member of your team, from the cleaners in the hospital, from the medical assistant, from the nurses, everybody in your team is very, very important to have a very good patient outcome. I think this is something that is being missed in most of the developing countries, okay? Everybody is very important in your team. And you as a doctor, maybe you are the chief of service at that branch, you need to ensure that your team is up to date with evidence-based practice, get them involved in continuous education. That will help you tremendously. I just want to comment that respect, okay? It doesn't matter how educated you are. Everybody deserves to be respected. And I can literally tell you that I have trained medical doctors, but I'm a nurse practitioner. Experience matters a lot. And even when you are in the hospital and you have all these residents, they rely on nurses. Those nurses have had years of experience under their belt. Doctors will come when they have emergency. Nurses are the one running codes in the hospital. So I just want to say respect is very important. And as a doctor, as a provider, I have learned you need to respect. And when you respect people, they will tell you things. They will help you without even knowing. Because there are times when you as a doctor, you make mistakes that can kill a patient. But who is looking behind you is that nurse. People need to be respected. Yeah, you've had all this level of education. Yeah, we understand. You know, I know in developing countries, doctors, sometimes they feel like they are the mini God. But I just want to say humility and respect will take people to higher height. When you respect your team, you accept that everybody input is valuable, you're going to have a very good team. And just make sure you train your team. Not in a condescending manner, but you train them the way you want things be. It should be evidence-based practice. I understand healthcare is evolving and you have people that are still stuck in their old ways, but you need to let them know there is change. And with this new evidence-based practice, our outcome is better, you know. So that's just all I want to say. Continuous education, respect, train your team the way you want them to be, and get them involved. That's all I have to say. Thank you.
Thank you very, very much, Dr. Tongowo, for that wonderful contribution. Respect, evidence-based practice, and get your team up to date. Dr. Platin, you can unmute yourself and go ahead with your question. Please, if any other person has a question, you can just indicate with a hand show. Thank you. Dr. Platin, over to you.
All right. Thank you so much, Dr. John, for the opportunity. I'm sorry I can't put my camera on. I'm in darkness. Yeah, so I'm Dr. Platine from Cameroon, practicing in the suburbs. It's actually been a great session, getting to listen to my master, Dr. Esene Ignatius, who inspires me a lot, and to hear from Dr. Nyempa and Dr. Tongawa. Yeah, it's my first time of connecting with them, and every other person, especially Maxwell, also spoke, and Kendria spoke. It was amazing listening to your amazing points. So I'm not sure I have more of a question. It's more like a comment. I picked a couple of things from every presenter or every panelist, starting with the idea of the difference in the knowledge gap or the knowledge gap. And Dr. Ignatius emphasized that we should if we should remember one thing from this webinar, it should be complementarity. Yeah, that doctors and nurses are more of complementary parts of the healthcare process. So I think that was very key, and the idea of competence, and then Kendra talked about scope. So I will try to bring these these three together to perhaps constitute my comment. So when we talk about doctors and nurses having this Cold War, I think that firstly it's because I understand that some speakers might have sounded as like nurses have to be equal to doctors in some way, talking about leadership positions. And first, to speak to that, I think leadership positions, like Kendria emphasized, should be a function of competence and a function of the job description. Just because doctors are not directors or nurses are not directors of regional hospital doesn't mean for us to work better, for us to work well, nurses have to be given those positions just to satisfy that. I think those positions have job descriptions and have qualifications that are needed for some reason. And of course, there was emphasis on the fact that also perhaps the courses taken during the training of a doctor might be different from that of a nurse, and that might go into the kind of leadership positions they can take. So I think if we want to sound like what doctors can be, nurses can be, we are trying to kind of bring them into equality, which is not exactly what we should be looking at. I think we should be looking at complementarity, where nurses understand the scope, in Kendria's word, the scope of their job, doctors understand theirs, and they are able to collaborate. The nurse should know that, okay, this is what I'm supposed to do, and this is where I end, and the doctor knows that this is what I'm supposed to do, and this is where I end. Yeah, so it's not a question of nurses taking roles that doctors take, or doctors turning around to take the roles that nurses are supposed to take. No, I don't think that will be the case, because it will be it will rather fuel whatever is going on, because it will be kind of a fight of somebody who is trained to be doing a particular job, trying to do a different job, or trying to be able to replace someone trained differently to do their job. So we should look at it as like more complementary. And of course, nurses should have a say in the policy makings, decision makings that affect the nursing profession, because it will not also be very good that doctors are sitting to take decisions that affect nurses without nurses being represented. That one is totally out of place, and of course it should be done. And with the issue of competence, yeah, I'm really a proponent of the fact that nurses should keep being educated. In fact, in where I work, I have been trying to institute a situation where we have continuous learning opportunities for nurses, perhaps like neonatal resuscitations, you know, areas where I understand that my nurses are not very competent. I see how we can collaborate to come together to run workshops on that, just to ensure that if I'm away and a certain patient comes, I will be confident that the nurse on duty can be able to do this and that. That's empowerment. So I think that's very important for nurses to keep to keep going forward, so that we can work together as a team. And the competence of a nurse should not be the competence that aims to compete with doctors, because I understand the cost, but we want to be careful on drawing those boundaries, because what I've experienced working in the suburbs here and in Cameroon in particular is that the healthcare profession is poorly regulated in a way that you see situations where nurses do things that even general practitioners might not want to do because of the risks involved, but they do it because there's a sense of competence that goes beyond what they are trained to do. And I think that's a road we will not want to tread. So I think that we want our nurses to be very competent. with their own limits, doctors to be competent with their own limits. I cannot go to do brain surgery that Dr. Esene does because I attended a webinar talking about brain surgery, or because I read a book and I think I understand brain surgery, or because I assisted Dr. Esene several times and I think I can do what he was doing. So we want to draw these demarcations, and again, to emphasize on the idea of the scope that Kendria said, that we should understand our profession, understand our limits, and then to collaborate properly. If you ask me, I will tell you that the main reason why doctors and nurses have been having this, kind of Cold War, if we want to use that term, is because they don't understand their boundaries. Sometimes doctors get mad at nurses for doing things that seem to be infringing in the doctor's, level of competence or something. For instance, there are times they quarrel because a doctor might prescribe a medication, and perhaps because the nurse feel that they have had some experience and they can do better, they might change the prescription without informing the doctor. That's a breach of competence, like because someone feels that they already know something, they go about doing it when they have a doctor who is supposed to do that, write the prescriptions and certify. And so I think it's really understanding what we are supposed to do as doctors, what we are supposed to do as nurses, the limits to that we foster this collaboration. So much so that a doctor telling a nurse, for instance, to tell a patient every 3 hours to prevent bed sores should not sound like a command. The nurse should understand that this is what I'm supposed to do. Because the tendency is very often when a doctor says, okay, perhaps we should do this as a team to ensure that this patient does this, sometimes some nurses might be offended because they feel like the doctor is giving them a command, and perhaps that was not the intention of that. And it also goes the other way around. Sometimes doctors feel like nurses are trying to command them around or push them around, and all of those misunderstandings of who is supposed to do what are really the main causes of this conflict we are having, because nurses go home feeling like this doctor is over disturbing me, he commands me up and down, he does this. Same as the doctor might be feeling that this nurse is kind of fighting power with me or something, wanting to be a doctor in my world where I'm the doctor also. Those are things that we really need to emphasize on and go home with the complementarity that Dr. Esene highlighted, understanding our scope, knowing where our profession ends and knowing where the other person takes over, and then working together, focusing on the patient, leaving our pride aside, leaving our personal, our egocentricities and all of that aside, to focus on the patient, so that together we can really foster healthcare in our setting. Thank you so much.
Thank you very much, Dr. Platin, for your contribution so far. I think you actually contextualize it for those of us in the suburbs. Thank you. Any question, any contribution? Please, if you have a contribution, let's try to keep it short and not reiterate on points that have already been made. If not, we are going to leave the place by 12 midnight. So any...
Hello?
Yeah, okay.
Hello?
Yes, you can unmute yourself and go on.
Hello?
Hello,
yes, you can go on. You can go ahead.
Okay, I'm Evelyn Yankio, speaking from Liberia, president for NRC Chapter 1 Canton, Nima County, Liberia. Yes, what the doctor was just saying there, my contribution there is the doctor should know that the nurses are the backbone for them. But sometimes the way in which you will tell someone to pick up your order, it will make the person to understand. But some doctors, they don't know how to talk to the nurses at all. And they forget to know that we are working on our own license. Doctor is working on their license, and the nurses are working on their. So if you choose to be a doctor, it doesn't mean that you should talk to the nurse any kind of way you feel like talking. So we all have to work together that our work will be super. Thank you.
Thank you very much for reiterating on the fact that the manner in which we speak to one another really counts, and it shouldn't come out like some sort of a command when we talk to our colleagues, be it a nurse addressing a doctor addressing a nurse. Thank you very much for that contribution. I don't know any other contribution or any other question for us to wrap it up.
Very quickly, sorry, I cannot raise the hand because I'm sharing the screen.
Okay, yeah, you can. Okay.
Very quickly, I just would like to witness the fact, and I'm an Italian nurse in UK, and beside my role as a nurse, I also a career coach for international nurses. I really have this concept in my heart because this is problem happening in Italy too. So, but I would like just to let you know that regarding the policy maker role, I just want to let you know that in other part of the world, nurses are already in the parliament, are already overall in hospital on a high position, and not because they have to take the place of the doctor, simply because they see things in the perspective of the nurse. So we manage things differently because we have a different role. But we need to manage. We need leadership position, not for ourselves, to make ourselves feel better, to let our ego grow, but simply because the patients in the day by day situation need a leadership perspective, which is different from a doctor, which is a nursing perspective. Thank you.
Thank you very much. Thank you very much for that insightful one. Okay, please, any other contribution? If not, then Stanley, are you with us?
I am present, Doc. Good evening.
Okay. Okay. Yeah, good evening. I noticed you had issues with your connection. Okay, so please, just write down and give us a take on this topic and what you have to say with regards to this before we call it a wrap for today.
Okay, thank you very much, Doctor. I would like to appreciate Dr. Ignatius Iseni. I like to call him the Cameroon's Ben Carson. Actually, his points are so powerful and I concur to them all. Now, trying to talking about the role of a nurse in the healthcare chain and that of a doctor and where the problems are arising from. I would say, first, when you look at the background of nursing, you see that nurses, first of all, when you look at like back in history, you see that in Cameroon, the way nurses were considered is still the same today, making it a kind of how can I put it? There's no innovation in the nursing profession in Cameroon, and that is why I think the co-wall between the doctors and nurses is coming from. Another thing is when it comes to the problem, I think about who a nurse is in Cameroon, because in Cameroon the government actually has not really defined the entry point to who is qualified to be a nurse. And you see someone who is being trained for 9 months, standing and performing what is supposed to be performed by a nurse with a BNS, which is actually not correct, and they are actually equally implementing what they have been trained without having a rationale to that. And that's where doctors tend to use it as an advantage to torment or to consider nurses as subordinate. So using bridging the gap between knowledge is going to be something that can address this co-wall, and also the government trying to give nurses the full autonomy that they need to practice efficiently, and defining the role and the rights of nurses in the healthcare system. Doctors are not supposed to give nurses instruction. Nurses have their hierarchy, and if in the healthcare system nurses are given the autonomy to practice, I think nurses can do better, and our patients in the hospital can actually feel the effect, because all of this is centered on patient care. No one is trying to fight over another person's right to power. All of us are complementary. Anybody has something to offer. So when we acknowledge this, we are going to be better, and our healthcare system is going to be better. Thank you very much.
Hello.
Stanley, thank you very much for that short one. I think that said, if there's no other question or contribution, we are going to call it. Yeah, okay.
Hello.
Yes, who is there, please?
It's Ndasi talking.
Okay, okay.
Okay, I think they have basically set some key points, and I think it's very, very pertinent. But I'd like us to, we have too much rely on the fact that we are looking at clinical scenarios. And when we look at clinical scenarios, we keep belittling the capacity of a nurse just being at the center of bedside care, which is not the stake as per now. So as per now, nursing has moved into a standard that it has so many pillars of autonomy. But if you look at the clinical implications, it's not been seen. It's not been seen. I think in Cameroon, where we actually see nurses practicing at some levels of autonomy, is only at the regional hospitals and our special hospitals of the first and second category. Like I'm talking about Hôpital Central, Hôpital Général, La Quintini, regional hospitals where a nurse can go on clinical basis, can go as far as possible to be a care coordinator. And in the top administrative body, he assumed the roles of, he or she assumed the role of being a GS, and he stays there. That's not what we are seeing today. If you look at our setting structurally today, nurses, they feel like we have gone to school and we are having PhD already. What are the essence of having all this certificate if we have no role to play in administration? What would be the essence of me having masters in nursing, having PhD in nursing, if in essence, I cannot sit somewhere in a boardroom and decide and make values of my masters and PhD? If you come at the clinical domain, these documents are not even considered by our ministries. It means what they call you if you're being recruited in Cameroon like a nurse, or in some African continents like a nurse, what they call you, they'll call you a registered nurse with a status of a PhD. It means a PhD is coming like a bonification. It's not coming like a recognized recruiting certificate, which is not the cause. And so long as they cannot give us that status of recruitment, so long as we cannot integrate the healthcare system to practice with those status, we will keep biting and biting because we don't have persons that can decide for us. Like for instance, we have seen so many clinical cases that have occurred in our clinical settings today, and you see that the first person that have been sanctioned are always nurses or internship nurses or midwife, but you will never hear a day that they are sanctioning medical doctors or they are sanctioning doctor specialists, because those are the helm of the decision bodies are of these leading professions. So it's a call for concern. It's a real call for concern. That's where the real war is. And remember, before you want to assume a top administrative position, you start first by being at the bottom of the care. It means you have to gradually move up. Now, the experience you have at the lower point of the ladder makes it difficult. It makes it difficult for you to like actually work well, because you already have a negative impression of who your opponent is from entry point of clinical experiences. So no matter how you try to bring in the dialogue, it's just like it's a burning a dagger in your heart that you feel like, I just have to air out. And once you air out, you see that the majority will turn up to be still doctors, and before you know, they still quench you up with their ways, and it ends there. So what we are saying today is that there should be equitable leadership. We have nurses today that have learned management, that have learned hospital management, that have learned leadership. They can assume positions of directors of hospitals. And why not be Secretary General or the Vice Secretary General of the Ministry of Higher of the Ministry of Public Health? It speaks well. But if you want to look at all the nominations, all the top nominations at the ministry, everything is being covered by the medical councils and the medical doctors and the physicians and their various specialties. It means that nurses at all points have been radicalized and vandalized in a state where they will always be subordinate. The moment you don't have somebody to look up to in case of trouble, in terms of danger, it means yourself, you are at danger at all points. So that's where that's where the real world is. And until the government does not give us equity in decision, like nursing is not just the only call. You have midwifery, you have laboratory technician, but nursing is being more prominent because 70% of all the healthcare forces in human resource are being represented by nurses. But only 2% of these nurses are in boardrooms to decide. What can they decide? What can these 2% really decide on the table? So it's empty. So you have to revise back text, revise back policy that will give nurses who have learned hospital administration and leadership to assume top leadership positions and see how the narrative can change. That's the point. It's not like we're looking at nursing from a bedside point of view. No, we're not looking at nursing too much at integrating the healthcare team too much, because even if you want to go by that rule, if anything happens, the fraternal law, and there's one very bad thing too about the nurses is that we don't have solidarity within ourselves. The lack of solidarity, the disunion, and the too much low esteem and low autonomy that we have is killing everything about us. And these things are only coming for the fact that we have nobody at top decision-making capacities who can actually advocate for us. So we're actually living in hell, where each and every person just feel like, I'm taking a copy, and the moment I die, I'm living my life, and everything ends there because I have nobody to look up to, but I have a call to answer. So it ends there. That's where the world is. So until we get to open a window where people can adapt their opportunities and assume some opportunities to share out what they know, there's something in life we call self-actualization. If you cannot realize your esteem, no matter how you're being paid, no matter what you do, that influence of you will still leave you in a psychiatric, in a psycho episode where you must need consultancy. So that's the point we are. That's the point we are saying here. Thank you.
Well, thank you very much, Maxwell, for that eye opener, I think, on the path of nurses. So we should know that at the end of the day, it's not about bedside bed. We are trying to give the nurses a voice. So that said, I don't think we have any other inputs. Well, we've gone beyond time, and I would just like to get a closing from the CEO of Nurse in Charge. Thanks to them, we are here today. And so, Doctor, please just give us a closing remark before we bid each other farewell.
Thank you, Jean-Paul. Thank you, everyone on this Zoom platform today. And I truly, from the bottom of my heart, I want to say thank you, because if you did not care for nurses, you won't be here today. You would have been maybe hiking somewhere on the beach, or doing a cookout, or whatever it is you would like to do with your time. But the fact that you care about the matters that are concerning to nurses, that is why you're here today. So if you look in the chat, I have posted our link to Nurses in Charge website, because I truly want you all who are not yet members of NIC to please just do your own research of our organization. Just do your background check, and please, after you do that, join us, because this conversation is not over. This is the opening of a brand new relationship between you and NIC, because we have planted the seed in you, seed of knowledge that there's something wrong somewhere, either between the conversation we're having is not being transcended properly. So we're having malfunctions in our patient care, or even just the way we work around each other. So NIC is truly here to build and cultivate a positive work environment. The work environment culture that are faulty, we're here to see how we can strategically partner with each other to change the dynamic in the work environment that are not suitable, neither for us nor our patients, and worst of all, not for the community at large. So this is the mission we're on. And being a faith-based ministry, and I said ministry, not organization. We are an organization, but it is a ministry, because we are stewards of the healing ministry that Christ established. So how can we work in healthcare and not love each other and not communicate properly, and not in the end of that, how you call it, at the end of all of that interaction, give quality care. So as stewards, we have to take good care of ourselves and the patients we're taking care of in the world at large. So please do visit our website, see what we're all about, place your membership, and come and learn more and just collaborate with us on a global platform, on a global level. Thank you so much for our meeting today. Thank you to our moderator who did a phenomenal job. Thank you for everyone who took upon their time to be here today. And those who are watching, thank you again for your interest. From my heart to yours, we have a lot of work to do. And this is just the beginning of that. Thank you.
Thank you very much. And
thank you very much.
it's a good night for me. Dr. Tongowo, I left you a message. It's like you did not see.
Are you
I
hearing
left
me?
you a message.
Hello?
Yes, Dr. Tongowo, please, I left you a message.
Oh. On my WhatsApp?
No, on this chat, on this WhatsApp, sorry, on this Zoom, on the Zoom chat, a private message.
Let me see.
Okay, it's a good night for my end. Dr. Yempo, thank you very much for giving me this platform, and to every participant, I am grateful, and I